We're a different local health district to Broken Hill, and before I get accused of being a silvertail, I've started school in Broken Hill and then completed school in Western Sydney in an agricultural high school that's not the well-known one, so I'm just visiting amongst the silvertails. So we've got a large population, 11% of New South Wales cancer patients live in northern Sydney. We've got more than 5,300 residents diagnosed each year with malignancy, and our LHD is bigger than Adelaide. We've also got 11% of the cancer deaths in New South Wales, and our 5-year survivals for all cancers are at or better than New South Wales average. In terms of our overall cancer-specific mortality, it's 0.86 compared with the rest of the country. So our LHD does well. We do well probably because we've got well-coordinated systems, but also we've got good patients. So they have a low smoking rate, they're fitter, they're healthier, they're less obese. So you've all heard the story about how do you pick the Mossman lady at the funeral. She's the one in the black tennis dress. So it's that kind of healthy, aware population. We also have a high percentage of private sector activity, with up to 70 or 80% of surgical resections undertaken in private centres. We've got 3 of Australia's largest private hospitals, and about to become 4 with the development of the Northern Beaches Hospital that's about to open in under 60 days. So this is just to demonstrate the sort of data we can get from ROBCO. These are the adjusted 5-year survivals by cancer types, and Northern Sydney is in blue, the rest of the New South Wales average is in black, and as you can see we do pretty well in most cancer types, but it also demonstrates to us the types of cancers where we need to work harder to improve outcomes. We've used the ROBCO report quite well. I think we always start sceptical with any new amount of information, but then you get to learn how to use it and it becomes very interesting and empowering for us. So we've learned to understand our strengths and weaknesses. We've learned from the ROBCO report that we did 1 in 2 of the pancreas cancer resections in New South Wales, and then we went back and looked at the data for those outcomes and found we had the best results probably in Australia. And so that then has enabled us to get a support from New South Wales Health to have a pancreatic cancer centre of excellence and work with Cancer Institute New South Wales on enhancing that further. It's also helped us to define clinical variation in activity and management of a number of cancers based on the caseload that you've heard of before, and again try and limit activity in small centres and encourage collaboration between co-located centres, particularly the North Shore Hub with North Shore Public and North Shore Private. Interestingly enough, there is no sort of established MOUs between the public and private centres within northern Sydney. Our nurses are not, our care coordinators have just been told by the Treasury Managed Fund that they will not be indemnified if they go into the private centres, so we've had to stop our care coordinators going into the private places, which we think is a dumb idea and may change around election time, particularly if people are aware of it. And we hope that the patients in public and private centres can get the same sort of facilities. So these are some of our data for pancreas cancer. These are 115 potentially operable patients treated with neoadjuvant chemotherapy, and we found our median overall survival for the whole group is approaching 31 months, which is very, very good for that disease. If you didn't have an operation, for instance, the survival is 13.4 months. In those who have an operation, it's 35 months. So it demonstrates that if you have high volume, highly expert care coordinators, nursing staff, theatre staff, radiation oncologists, medical oncologists, you start to get better results. And this is the kind of data we have been encouraged to get by utilising ROBCO information. So we do have clinical variation, but also this slide demonstrates some of the problems we've had in northern Sydney in terms of getting data, and the Cancer Institute have done incredibly well to start to solve this issue. So these are breast resections in northern Sydney between 2013 and 2016, 805 resections, and you see that 635 are done in private centres. So therefore, if you don't have data from the private centres, you're not really getting the full information about this occurrence. And last year, for the first time, we were able to get data from Macquarie University Private Hospital, Sydney Adventist Hospital, North Shore Private and the Mater. It was a bit of a big day going to all these places with the Cancer Institute people, but we were able, and they were very interested in having their data because most of them found that their data were very good and comparable, if not better, to other places in New South Wales. So they realised that this was a useful thing to do. These are some of the sorts of variation that we see in around New South Wales and in northern Sydney in terms of various procedures, particularly breast procedures. Just to demonstrate, this variability does have in our hospital. You saw this before, mastectomy versus breast conserving surgery. New South Wales public average 38%, and there's quite significant variability across the hospitals in northern Sydney, and we've been able to work with our specialist breast surgical network to go and find out why is this variability happening. And similarly, there is significant variability in the proportion of patients having immediate reconstructive surgery during that time. New South Wales average there. Northern Sydney LHD is higher, but significant variation across our hospitals. And so we've again tried to highlight these to the hospitals and their surgical units, although even for medical oncologists it's hard to get surgeons to talk to you. But we can work with other surgeons to talk to them to make them realise that perhaps they need to change their behaviour. These are just some of the issues of caseload, and some of our smaller hospitals are not achieving the desired caseload. So again, we've worked with the administrators to try and avoid elective surgery for those cancers where there is a demonstration that caseload is important. So for instance, at Manly and Mona Vale Hospital, we've indicated that they perhaps shouldn't be undertaking complex rectal surgery, esophageal surgery, pancreatic biliary surgery if they haven't got the appropriate case numbers. It also raises the issue for North Shore that we need to have a campus approach, because some of our numbers, even though it's the same surgeons between the two hospitals, same MDT, different theatre nurses, but we need to be regarded on that place as a campus with two hospitals, so that our numbers are recognised as being adequate across those two. So these are some of the interventions that we've looked at: discussions with facility executives, clinicians and surgery and anaesthesia clinical network, assessment of planned versus unplanned operations, so try and avoid the planned surgery in those without adequate caseload, redirect the caseload to facilities meeting minimum requirements, improve linkages between MDTs across the LHD. Some of the smaller hospitals hadn't been discussing patients in MDTs, even in the Sydney circumstance, so we've tried to encourage that, and address difficulties with non-cancer clinicians. I think we're grown up with the Cancer Institute now, we know it well, trying to convince some people who don't routinely work with the Cancer Institute that perhaps it's a good idea to collect data to tell GPs about the recommendations for their patients, and to work in the way that we have grown accustomed to is taking some work on our behalf. Clinical trials has also been important for us, and the Cancer Institute gives us data about clinical trials, and these are some of the trial data we get. This has been very useful for us. We found that it was taking an average of 120 days at one point to get our trials through ethics and governance at our hospital. We managed to convince the LHD that they should give us the trials budget and be able to work with that, and we've been able to enhance our trials budget, get things through ethics and governance faster because we highlighted it, and make our trial system work much better. So overall, the publication of the private facility caseloads has been important. We've had strength in MDT referral processes. We've overcome issues with governance and ethics, and we've taken over cost centres for trial management. So that's just a brief demonstration of the type of empowerment that the ROBCO reports have given us in a different health district in New South Wales.
Look, thank you so much. Would you stay there, please? Just so you know, we are going to hear from Dr. Craig Earle, our Canadian speaker, shortly. But could I just ask Roo and David and Melissa to come up and to sit on the edge of the stage? That they're live microphones, and David, I think you've got another one there. And I want you to ask each other questions. Have you got any questions for the lady from Broken Hill? Because this is fantastic. We've had Broken Hill in the North Shore. You couldn't get a better contrast. Seriously, what do you reckon?
Look, I think the MDTs it'd be interesting, and what the future. I know Broken Hill had 32,000 people when I was there, and I think it's 23, 24 now. What's the future for Broken Hill and this type of complex cancer management?
Can you stand up just so they can stare at you? Yeah.
So in regards to MDT, what we've organised is basically using remote MDTs. So we tap into Adelaide MDTs. We've also got a breast surgeon in Mildura who we use, again, if a woman wishes to have surgery at home. So we still access MDT remotely for those people who need that level of oversight.
Have you got a question?
And it's down to 19,000, Stephen.
19,
Yeah.
wow.
Ask him a question.
Ruma, I don't have a question for Stephen, but someone else might.
For both of you, actually.
Stand up and speak more loudly.
Okay. Is that loud enough?
But no, speak up, seriously.
Okay. I've just got a question that I was thinking about when Stephen and Mel were speaking. I just wonder what you think the role of resilience is in terms of people who might be embarking on using these reports, might go and pick up some data somewhere or pick up their ROBCO reports, the role of resilience, because I think you both kind of alluded to
Role of resilience.
interesting conversations that you've had to have. So I wonder what you think about the role of resilience for those change managers, quality improvement champions that are out there, and other clinicians.
We work in New South Wales Health. We're as resilient as all hell.
Stephen, get closer to the mic, man.
No, I think
closer to the mic.
I think you need resilience to work in any of these circumstances, but I think as long as you know that you're working for the welfare of the patients, I think you can put up with things. And usually it's a process of educating people about change. And I don't think any of us cope well with change, particularly as we get older. And I think the hospitals are no different. And I think you just have to demonstrate to people why it's important and how it will improve their way of life. And I think having the patients more involved and aware of all these issues is very important.
Look, I've got a question, because you've put it out there with your talk. What do private patients and their families need? What questions do they need to ask if they get a cancer diagnosis? Just quickly, I had a care coordinator, a highly experienced nurse at St Vincent's, and access to a multidisciplinary team. But I'm not sure that's true for all private patients. It seems to vary enormously. And I spent more time with allied health and nursing after I got out of my bunker, and I loved every field my radiation oncologist gave me. I didn't mind the drugs your lot gave me either, because I got them. Anyway, small joke late in the afternoon.
I think the main questions are, what are my out-of-pocket expenses going to be for your surgery and the anaesthetist, particularly the anaesthetist? What's the alternative? Where can this be done better? And what are your results like? Because I think they all think that they're, extremely good, but it'd be nice for them to have some data to show how well they perform.
But what about access to a care coordinator and a multidisciplinary team? I could be in some private locations and I might as well be in Broken Hill. I feared that, but I'm listening.
Yeah, no, I think that care coordinators should ideally be made available across the board for people no matter where they have their treatment. I think I picked on the fact that they're not allowed to go into the private hospitals from the public, but I think also the private hospitals should be contributing to the cost of the care coordinator, so that this isn't just related to the public purse. They're making money from their procedures, from their surgeons, and I think they should be contributing to the cost of the care coordination.
Your thought, David, you understand. Do you mind standing up as well?
Yeah, sure.
Thank you.
Look, I think the other issue that has really been highlighted across the 8 years is that we can't put a cigarette paper between the public and private. We've got some excellent private hospitals that are matched by fantastic public hospitals, and we've got some private hospitals that are struggling just as much as some of the smaller public hospitals. And although we've highlighted the Silver City and a Silvertail this afternoon, this is not about regional versus metro. Some of our metropolitan services are struggling more than regional centres in the desire to provide high quality care. So, I think the issue that you're raising of private versus public, we see exactly the same problems in both systems, and both systems have to systematically address those issues.
And so are you hoping that what we're hearing about today, Reporting for Better Outcomes program, is one of the tools where ethical and leading clinicians, in a partnership hopefully at times with patient groups, can work in both sectors where there's lower results?
Look, this is about improving cancer outcomes for everyone in the state. The remit of the Cancer Institute is agnostic to whether people are in the public or private system. We want to get great outcomes.
Look, I want to bring up our Canadian friend, but I've been given a question by a lady from a multicultural background. I'll never come at CALD. I just can't go that far. I'm still back at multicultural, who couldn't stay. And so I want anyone to answer this one. There is limited data on ethnicity, country of birth, interpreter use to inform better screenings and cancer care outcomes for the multicultural communities and refugee communities. It is really the elephant in the room. Who should we be speaking to influence to generate better data for multicultural communities? So that's the assertion of my questioner. Who'd like to go first?
I'll kick off if you like. If it's screening, then right across the state, we are working with communities, wherever they are, to improve screening literacy and screening participation. And let's be honest, there are culturally and linguistically diverse communities where the screening rate are the best in the state. So, and everywhere we've invested, we have seen an improvement in screening participation. In cancer services more broadly, you know, those interpreter services are there. The data are collected and are collected well in the system at the moment.
So in that report, the ROBCO report, have we got multicultural measures reported?
We absolutely have for screening, but there are other areas that we will expand into. As Roo and I illustrated this afternoon, it grows every year and it grows in sophistication. We had to start somewhere, and certainly for breast screen, the data are there and have been, I think, since year one. On culturally and linguistically diverse communities, Aboriginal and Torres Strait Islander communities, and the community more broadly.
Yeah, can I comment on that from our LHD? They highlighted for us in the ROBCO, the report, that our Asian community in the North Shore wasn't having as much screening both for breast cancer and cervical cancer as the Caucasian community, and that's something that we've taken up with our LHD to try and overcome any issues in regard to that.
And so where would... I'm just responding to this question, and do you want to come over here, beautiful assistant, to me? Are there areas... Where do we go next to improve the quality and extent of data for multicultural communities? Could I put that question in that way? Do you have any thoughts on that?
Look, I think they're already doing it, and I think that will just improve over time as the extent of data that's being collected and the currency of that data improves.
Roo, can I have your thoughts on that? What are you doing now, and what do you hope to do in the future?
As Dave mentioned, I think we've already got the culturally and linguistically diverse population data in the Reporting for Better Cancer Outcomes reports at the moment. But I think there are probably two things. The first thing being, I think it is growing over time, and indicators are growing. The reports are getting bigger and bigger. You need a bit of a trolley now for some of them. But in all seriousness, they are coming, and especially going back to the earlier presentations, the better we are going to get at linking, and we are looking at a project with linking more data, linking ABS or Australian Bureau data with the data that we have now. So the better the data gets across the system, and as we continue now to link next, I believe it's coming. And the third thing I will say is when we had the multicultural officers across the state coming in to see us and looking at going through the ROBCO reports, one of the things that they started doing, which was quite interesting for me, they started looking at the data by local government, or the information by local government areas, and there's a lot of expertise and knowledge out in the system about the setup of local government areas and what the populations in local government areas are. So by looking at that, instinctively, people were going, okay, this is the population that we might need to start thinking about. And they were going into the areas to do deeper dives. So just by, again, feedback and sharing that information with people with that expertise from the Multicultural Services New South Wales, it was fantastic. They started that conversation and had run with it in the meantime.
Thank you so much. I'll just get one question from our sheet.
There appears to be a high focus on women's cancers in ROBCO and less on men's cancers. Will 2019 have data on this?
So this is one of the app questions.
Well, the number one killer for men in cancer is lung cancer, and it's well covered, both in terms of surgery and in terms of other therapies, radiotherapy. If you're referring specifically to prostate cancer, if that's the question, the answer is yes, but we're working with the National Prostate Cancer Outcomes Registry. We are the New South Wales partner. The first of the public reports from that registry will be out in March 2019, and we'll be looking at what we can include in the reporting for better cancer outcomes as a result of that.